Let's enjoy chest radiographs with Dr. Y. Session number 3, pneumothorax. こんにちは、皆さん。今日も흉부X선楽しみよ。Let's review the session number 2. You and we now know clearly this young healthy lady's lobe anatomy, right? What is the lobe of this blue color zone? Yes, correct. It is right lower lobe. This is also the review of session number 2. We now know clearly and very clearly the chance of false positive nodule, mass, or consolidation in a lateral film. The both right and left inferior pulmonary vein. Right? Very good. Let's move on. Today we're gonna start with abnormal findings. First case. Yes, I suggest you to remember again in the first session and second session the normal chest radiographs anatomy, frontal and lateral films. So if we remember the normal appearance of the radiographs, we can easily point what is abnormal between normal and abnormal films. Let's look at the film on the left side. Yes, it's very easy for you. Yes, we all know this one. What is abnormal? Yes, right side lung is abnormal. How abnormal? Yes, although indescribable, we can say that this is pneumothorax of the right side. Yes, correct. It's thrilling to start with abnormal findings. First case. This is pneumothorax. Yes, session number 3 is about the pneumothorax. Presence of gas in the pleural space is defined in the Fleischner Society as pneumothorax. What do we see actually on the film? Medially, this is the visceral pleura, and inside, these are all collapsed lungs. And laterally, parietal pleura will be here and the thoracic wall. In between, there is only pure gas, pure air, without lung tissue. So there is no pulmonary artery, pulmonary vein, or alveolar structure here. That is pneumothorax. Let's talk about the gravity. I think gravity is important in chest radiographic evaluation. First, in erect view, gravity is usually directed toward the inferior portion, but in supine chest radiograph, gravity is not to the inferior portion, but to the posterior portion, from anterior to the posterior portion. That is the different point of erect frontal view and supine AP view. And number 2, so in the gravity, the light is the material, the air is in the upper, and the body tissue, lung is in between, and the fluid, pleural effusion or hematoma is the heaviest one, so it's in the inferior portion near to the earth. Number 3, Sir Isaac Newton's law of universal gravitation is the basis of this one. Look at the apples going down to the earth. Okay, apple and the earth. Always on my mind. Do you like this song? I hope so. Which singer do you like better? Willie Nelson or Elvis Presley? whoever will be good to you. I would suggest to have gravity always on your mind when you see the chest radiographs. As I told you before, in erect film, gravity is toward inferior, but in supine view, gravity is toward posterior portion of the body. So air is up, fluid is down, because fluid is heavier than the air. In pneumothorax, in pleural effusion, and pulmonary edema, and this gravity is important. What do we see in this young man's chest radiograph? Probably erect PA view. Yes, what do we see here is visceral pleura. Visceral pleura in the medial side and the air in the outside without any remarkable tissue marking. And if we see meticulously, this is a bulla, maybe the cause of the pneumothorax. Let's see in the chest CT coronal imaging of lung window section. Yes, we see 2 cm bulla at the apex and the pneumothorax here in apex, lateral portion, and lower portion. What's the difference with the chest PA? The air collection is more in the lower portion. That's the difference of gravity. And we can also clearly find out the fissure, horizontal fissure and major fissure. This is also the position of a visceral pleura. So usually in pneumothorax, we can define the lobar anatomy, upper, middle, and lower, because fissures are divided. What is your opinion about this film? Now we are very familiar with this film. Yes, pneumothorax. Large amount of air collection in the apex, not in the lower portion. That means gravity is directing toward the lower portion. This is erect film, which means, and several small bullae at the apex, and as we see, fluid, transverse horizontal line of fluid here. Actually, this is hydropneumothorax. If we see and magnified with more meticulous eyes, this is minor fissure, upper lobe, middle lobe. This is oblique fissure, major fissure, and this is the lower lobe. And several bullae here. What do we see in the left side film? Looking normal? Something wrong? I don't know. But if you see the film on the right side, it is evident that this is pneumothorax. Large amount of pneumothorax in the upper portion with the lobar anatomy here. Yes, this film is expirated film. Patient's view was after expiration. In that case, the lung is more collapsed and the air is more filled at the pneumothorax cavity, pleural cavity. So it's easy to diagnose, easy to understand. How about let's go back to the original film, inspiration film. Look carefully with our eagle's eyes. Meticulous eye research will find this pneumothorax visceral pleura line here. So actually, if we suspect pneumothorax with this patient, we don't have to take this expiration film. Inspiration film is good enough for us to diagnose. Now we are very familiar with pneumothorax on expiration films and inspiration films. And fluid is heavy, air is light, okay, and many bullae at the apex. This is the cause of the pneumothorax, and the air leakage started from here. Most common cause of spontaneous pneumothorax among the young people are, as we have seen, the bulla and the apex. And many diseases itself cause the pneumothorax. This is, as we see, pneumothorax here. Do you expect what is the cause of this patient pneumothorax? Yes, tuberculosis. Very, very active and extensive tuberculosis of both sides of the lung. Maybe this be a cavity, consolidation, many of the twin-bird patterns. We can see these patterns all in this coronal lung window setting CAT scan image. This is cavity, pneumothorax, twin-bird of the bronchial lesion, consolidation, many twin-bird, all through the right and left lung. Please look carefully at this film, and guess what? We see the pneumothorax on the left side. This is a spontaneous one. What do you see the pathology of the underlying lung of this pneumothorax? Is the lung looking good? Right side and left side. You have some idea? Let's go to the next film. Let's recall the first session. First session of normal young man's chest radiograph. What was the difference with normal chest radiograph here? What's in the lung? The lung field is not clear, and maybe some kind of small cyst scattered all through the lung. Isn't it like that? Do you feel like that? Many cysts spread bilaterally all through the lung from the apex to the basal lung. Okay, do you agree? The name of disease is lymphangioliomyomatosis. As the name implies, there are many smooth muscle cell proliferation in the lymphatic and lung tissue. It is a kind of manifestation of the disease named tuberous sclerosis. There can be angiomyolipoma in the kidney, maybe brain tumor, etc. Let's see carefully the cystic structures here. Yes, we are getting more and more familiar and friendly with this kind of film, pneumothorax. Many bullas here, and the lung is not looking clear and good, and some fluid here. Yes, on the actual image of lung setting CAT scan, we see many large bullas and emphysema. This is chest tube and improved pneumothorax. That is emphysema. Among the old-aged people, the number one cause of spontaneous pneumothorax is emphysema. What do we see now in this film? Let's forget the right side of the lung. Probably this is a total lung collapse with a huge amount of pleural effusion, but let's forget the right side. What is this line represents for? How about this line? Yes, you know the answer, I'm sure. Do you see pneumothorax in the left side? Nope, surely not. This left side film is same patient's another day film. Yes, what is this line represents for? Do you think it's pneumothorax of visceral pleura? No, surely not, because the line is out of thorax. But in the outside of visceral pleura, it looks like pure air. But in the other hand, there is no signal of major fissure here. So we can surely say this is skin fold, not pneumothorax. The left side film is also skin fold because the outside of this suspected visceral line is filled with normal lung tissue, pulmonary artery, pulmonary vein, and lung tissue. So these two films are skin fold, not pneumothorax. Now, how about this film? This is an old man's supine AP film. In right upper lobe side and left upper lobe side, lines are visible. What are these lines represents for? I'm not sure, and you are not sure too. Really? Okay, in this case, what shall we do? Let's take a CAT scan, or just put a chest tube here. Let me see. Skin fold is famous when old man, old person, and thin person, and especially in the supine film. In other case, that is not a problematic. Old, thin, spine film. And I suggest you one idea. If you are not confident about the diagnosis about pneumothorax, take another picture, take another radiograph immediately. Then more than 99% you can solve the problem, whether this is skin fold or pneumothorax. Have you ever heard the name deep circle sign? This means circus is deeper than before. This is erect film pneumothorax. This is supine film pneumothorax. Let's look at this left side lower portion. The CP angle is more prominent than the right side without pulmonary vessels. So this is pneumothorax. And especially this diaphragmatic line is more evident in our eyes. It's a kind of Mach band effect. I'll tell you later if I have time. The pneumothorax is large enough to show at the apex and lower portion. So the circus schistophrenic angle is going deeper, but especially going deeper is on the AP supine film. Actually, diaphragm is inserted more than deeper than we usually suspected. Let's look at the left side. Usually we see that diaphragm is end here, but if we see on the right side with pneumothorax, that ends more deeper. So that is deep circle sign. It is evident on the supine film when the pneumothorax in the upper portion is not clear. Let's get more familiar with the deep circle sign on the AP supine film. This film on the left side shows no deep circle sign without pneumothorax, but the next day film shows deep circle sign, darker, deeper, black, and deep circles here with more evident diaphragmatic margin, and no pneumothorax at the apex is visualized. As I've told you before, that's why gravity is important. This AP supine film, in this film, gravity is directing toward the posterior. So gas or air is collected more not in apex but in anterior portion. So this is famous deep circle sign in the supine film. We remember this film of pneumothorax in young men. The same day after chest tube insertion, we found the hazy GGO or consolidation in the mainly peripheral lung with air bronchogram. What do we call this phenomenon? Yes, re-expansion pulmonary edema. After expansion, a kind of permeability edema has developed. It is sometimes fatal, and we should be careful about this. This usually happens when the re-expansion is so fast, so rapid. So we should have time to improve the pneumothorax. What do we need to enjoy the chest radiographs? I said before, anatomic knowledge and imagination and familiarity. I now want to add one word more, the curiosity. Like, subscribe will be a big support to me. Thank you very much.